In this video, we will discuss how to tape endotracheal tubes and LMAs to ensure security, move endotracheal tubes from one side to the other, tape a patient's eyes to protect from corneal abrasions, place an OG tube, utilize a twitch monitor, and place a nasal temperature probe. There are multiple ways to tape and secure an endotracheal tube, with many providers having a preference of one way over another. We will demonstrate a couple of the most common ways to tape an endotracheal tube securely. The first technique will involve using 1-inch silk tape, but half-inch tape can be used if that is your preference. We will start with a dog ear to better allow for removal later, and attach the tape to one bony prominence of the cheekbone, then going across the upper lip, and then around the endotracheal tube as low to the mouth as possible to create a tight, secure seal. We will then go across to the other cheekbone and create another dog ear for easy removal later. We will take a second piece of tape and follow the first piece of tape over the upper lip to better secure the original piece of tape onto the face. The endotracheal tube should be secure. The second technique mirrors the beginning of the first technique. We will still use the 1-inch silk tape, create a dog ear, and attach the tape to one bony prominence of the cheekbone. We will then note the endotracheal tube depth and secure the tape around the bottom portion of the endotracheal tube. You can circle around the tube twice if you want a more secure fit. Then attach the tape to the other cheekbone. We will then mirror the same effect, but from each corner of the mandible. Dog ear the tape, attach it to one corner of the mandible, encircle the endotracheal tube, and then finish the tape at the other corner of the mandible. The third technique we will show you involves ripping a sizable piece of 1-inch silk tape. We will then split it down the middle to about half of the length of the tape you tore. The thicker end of the tape will attach to the side of the patient's face, allowing for the bifurcation to be right where the endotracheal tube is. The upper portion of the tape that was torn in half will go across the upper lip, while the lower portion will wrap around the endotracheal tube. It is best to get as much surface area of the endotracheal tube as possible. When we intubate, we have the tube in the right hand, so the tube often ends up on that side of the tongue and the mouth. If the surgeon will be working on the same side of the patient that the tube is on, the tube may need to be moved to the other side of the mouth. To do this, pressure should be applied to the roof of the mouth with the endotracheal tube, moving the tube around the tongue and then making sure that the tongue is still swept over once it is placed on the other side. Then you can recheck the tube depth and retape it on the other side. Taping and securing an LMA is very similar to that of an endotracheal tube. You can start with the dog ear again and then go from one cheekbone to the upper lip and then encircling the bottommost portion of the LMA. I go around twice here for better securement. You can then rip the other side of the tape, create another dog ear, and secure it to the other cheekbone. Just like with the first technique, with the endotracheal tube, we can rip off one more piece of tape and follow across the original piece of tape on the upper lip. A second way to secure an LMA involves using either thin silk tape or thick silk tape ripped in half, like I am demonstrating here. Once you have two thin pieces of silk tape, you can secure the LMA in place. Start with one piece going from the cheekbone to the center over the upper lip, encircling the bottommost portion of the LMA. You can circle around the LMA once or twice and then secure the other side of the tape to the other cheekbone. With the other piece of thin tape, start at the corner of the mandible. You can then go along the bottom lip and encircle the LMA, mirroring what you did on the upper lip. Then secure the other side of the tape to the opposite corner of the mandible. Next, we will discuss placing an OG tube. The natural curvature of the OG tube should be used to help facilitate placement into the esophagus. Your dominant hand can hold the OG tube, while your non-dominant hand can grab the patient's jaw and fishhook it to better open the jaw and open the area needed for the tube to enter the esophagus. The tube should pass smoothly with little to no restriction. There is a risk of the tube coiling in the mouth, so if there is resistance or it does not appear the tube is going in the correct place, you can pull the tube back out and then place your pointer and middle fingers into the patient's mouth. This creates a tiny guide between your fingers for the tube to follow down the back of the tongue. Once the OG tube does not want to progress further into the esophagus, it can be connected to suction. Correct placement can be confirmed with the appearance of gastric contents being suctioned through the tube. If there is a whistling-like noise coming from right inside of the patient's mouth, it is likely that the tube has coiled in the back of the mouth. The suction should be disconnected and the tube should be pulled back to attempt placement again. A temperature probe like this can be turned into a nasal temp probe by taking off the sticky portion and placing a bend in the temperature probe. The temperature probe should go straight down into one of the nares. If there is resistance met in one nair, you can try the other instead. The sticky portion can then be used to secure the cord to the patient's face. The same temperature probe can be used in the armpit for an axillary temperature, like so. When preparing for a case, you can get eye tape ready by using the clear tape, creating a dog ear, and then making each piece of tape sufficiently long to cover the eye. These pieces of tape can be placed on the face mask for easy access, right after the patient has fallen asleep and does not have a palpebral reflex. Close each eye and place the tape on the upper eyelid, pulling down gently to secure the tape to the face. Alternatively, tegaderms can be used to close and protect the eyes if a patient appears to have frail skin. This is what a standard twitch monitor looks like. It is used to assess a patient's recovery from neuromuscular blockade. When checking a patient for twitches, use the train of 4 button, or TOF, that delivers 4 2 Hz impulses at 0.5 seconds apart. To turn this twitch monitor on, you turn the wheel dial on the side of the device up to 10. Once the train of 4 button is hit, you will hear 4 clicks that correspond with 4 light impulses on the twitch monitor, indicating that it is delivering the 4 stimuli. If no twitches are seen with train of 4, the sustained tetany button can be pressed for 5 seconds, with a long impulse of 50 to 100 Hz being delivered. This floods the neuromuscular junction with acetylcholine molecules, creating a better chance for muscle depolarization and a twitch to be seen. After sustained tetany, the twitch button should be held down, as this delivers 20 1 Hz stimuli that allow for observation of post-tetanic count. A higher number of twitches or higher post-tetanic count after sustained tetany indicates that the patient is closer to having 1 twitch on train of 4 back. Here we are placing EKG stickers for the twitch monitor on the ulnar nerve to monitor the adductor pollicis muscle that has a slower onset and recovery speed from neuromuscular blockade. This makes it a great site to assess whether a patient is closer to being fully recovered from paralysis. The red positive lead should be placed closer to the heart, while the black negative lead should be placed more distal. A demonstration of ulnar nerve train of 4 can be seen here. The facial nerve can be monitored by placing the electrodes just anterior to the earlobe to monitor the orbicularis oculi and corrugator supercilii muscles. These muscles more closely relate to the recovery rate of the larynx and diaphragm from neuromuscular blockade, so they may be advantageous to monitor when trying to keep the patient more paralyzed. Depolarization of these muscles causes movement around the eyebrow and face around the eye. An alternative site for monitoring when the hand is not available is the posterior tibial nerve behind the medial malleolus. The response of the flexor hallucis brevis is assessed by the plantar flexion of the foot.